Today we've got a really amazing agenda, some really great providers and service providers here in the Anchorage area. Obviously there's 6 people that we've got, and so if you're able to hang out a little bit longer, we welcome you in case presentations go over. Before we get started, we're gonna go ahead and introduce ourselves around the room, just your name, and where you work at and your role. And then if you're online, go ahead and share that as well. And then, yeah, my name's Rand Honan-Mkeha. I am the partnerships lead at A2P2 here in Anchorage.
Hey, I'm Matt Hirschfeld from Alaska Native Medical Center on board for A2P2.
Hi, everyone, welcome. I'm Tamar Ben-Yosef. I'm the executive director for A2P2.
I'll keep you leading guest director of behavioral health. Hi, Carla McGregor, senior director of behavioral health.
I'm Emma Cantor. I'm one of the pediatric hematology and oncology doctors at Alaska Pediatric Specialties.
I'm Jess Quinn. I work with the state of Alaska. I'm here representing the Alaska Cancer Partnership and our HPV vaccination.
Laura Mann, I work with Maxim Healthcare. We provide in-home nursing to kids that are dependent on ventilators, trachs, G-tubes, seizure disorders.
And I am Sue Brosnahan, key account liaison with GlaxoSmithKline, working in the ever-changing world of vaccines.
Hi, my name is Jim Hedgecock. I'm supervisor of Providence, Alaska PA.
I'm Jenny McGill. I am a physical therapist and lead rehab professional in our neonatal intensive care unit.
Hey everyone, I'm Nick Thurwinger and I'm the clinical nurse researcher at Providence Children's Hospital, as well as youth activation and the child identity.
I'm Joel Overville. I work at Providence and I'm the chief mission integration officer.
Karen Womack, and I'm here at Navigator.
Nikki Fire, I'm the nursing director for Providence Alaska Children's Hospital, which includes women's services as well.
Tim Marinelli, I'm a neonatologist here at Providence.
I'm Ed Michaels, and I'm the clinical manager of Nurse Family Partnership for Providence.
Emily Erlacher. I work with the Division of Public Health and the Perinatal and Early Childhood Manager.
I'm Donna Reisinger. I'm the communications and training coordinator with A2P2, and this is Joshua.
I'm Amy Simpson. I'm the executive director for programming for infants and children, which is the infant learning program that serves all of the Anchorage, Girdwood, Whittier, and 6 communities around the Lake Area. I'm Tracy Morgan. I'm a family support specialist too with Help Me Grow Alaska.
I'm Kathleen Mannix, the data policy lead for A2P2, and if you haven't signed the sign-in sheet, I'm gonna pass it around.
Hi, everyone. I'm Aggie Fouts. I'm the director of administration and finance at A2P2.
Hello, I'm Robin McComas. I'm the Help Me Grow Alaska program lead.
Hi, my name is Carmen Wenger. I'm the director of programs for the Alaska Pediatric Partnership.
Hello, and this is perfect timing because it leads you right to the welcome. My name is Meg Horvath. I'm the executive director of the Providence Alaska Children's Hospital and Women's Services. And thank you all to who could be here in person, and thank you to all online. This was such a great opportunity for us to get together and connect. And so just a little housekeeping, if you need to use the restroom out the door, take a quick right and all the way past the stairwell down the hallway to your right again. And then other than that, we have such an amazing agenda today. It is fully packed, so I do not want to take any additional time, but I'm happy to speak with each of you. Don't hesitate, I'll be hanging around for a little bit afterwards, but very thrilled that you could be here in person. So good to see some old friends, and we'll turn the podium back over to you. Thank you.
I just have to really truly thank you, Meg. Meg and Dawn Dupree have been just amazing organizers. Man, these two are a dream team together in terms of just like all the things you could think of for hosting an event. So truly, I appreciate you and your energy-filled emails. So thank you very much. So without further ado, we'll go ahead and welcome Carla and Elke.
Hi, we appreciate you giving us a few minutes to talk about our services with the PAMC. Right now, we have a mental health unit that we serve ages 12 to 17. On that unit, we do a lot of assessments that help being able to ensure the patient is going to the right care after discharge here. We provide individual, family, and group therapy, as well as psychoeducational groups in order to help stabilize the patient and step them down to either outpatient services or our community behavioral health programs within the community. We also have a consult liaison service line that we have a licensed psychologist that supports our children's hospital. They support the families, the patients and the caregivers. It also supports our mental health unit in order to help provide if we need additional testing to get the individuals placed to the right patient care. We also, one of the things that we are proud of, that we worked with Anchorage School District partnering in order to get 2 hours of school. So when our patients come onto the unit, they are not losing any type of school services. We also partner, my counterpartner, Tara Levin Curry, who runs our PMG clinics and our outpatient and the pediatric specialty clinic. They had like a list of almost 300 patients who needed autism diagnosis and testing. So they have a neuropsychologist, and Dr. Aaron, our psychologist, helped with that, be able to dwindle those testing down to like less than 30. So that was a huge commitment and need and support to the community that we have that Providence provided.
And then we only have a brief time with you guys today, but we wanted to extend an invitation to tour our programs and meet with our team in person. We have a lot of upcoming exciting changes that are going to be occurring working so far with across the state of Alaska. So please reach out, that's how to get in contact with us, and we help with each other.
And we love to show you our programs. Thank you.
Thank you so much. Like now,
When you're. Our pumpkin spice, hi, I'm Amy. I'm the executive director at Programs for Infants and Children. Been there for 30 years. Imagine. I'm also a speech language pathologist, and I started at PIC as a home visiting speech language pathologist, and I still do that occasionally. When I first came to PIC a long time ago, I didn't really realize that early intervention is different than being a speech therapist in a pediatric outpatient therapy clinic. It took me a little while to figure it out. So I just wanted to let you know that PIC is one of 15 infant learning programs that serve infants and toddlers with disabilities across the entire state of Alaska. So a baby born anywhere in Alaska has an infant learning program that serves them, that we provide really wonderful home-based pediatric therapy services, but also our developmental therapists, which are early childhood educators and special educators, are also part of our gavel of peace that do our work. Our services are mandated through the Individuals with Disabilities Education Act. And part of that is that our services are in natural environments, which means that they're anywhere that a typically developing infant or toddler would be in their day. So that's home, that's childcare, that's in the community. It's really important. We also feel that natural environments also means that we are doing our services within their daily routines and activities. So we're not pretending it's lunchtime, meal time, that we actually are there during lunchtime, if that's a problem. If going to the store is a problem, we meet them at the store, we do all sorts of things. We at PIC work through a primary service provider model, and that primary provider is that family's service coordinator. And so any services that child needs or may need, that person is responsible for coordinating children services within the community. That family service coordination makes up at least half of the services that we do. So when families first realize that they are their children have a disability or a developmental delay, it's kind of overwhelming. And they have to learn a whole new vocabulary that they never, they would have to learn. And so we're there to kind of help them through that process. And the best thing is that those services are at no cost to families, which is quite awesome. Just to kind of let you know that part of the IDA law is that there's timelines to everything that we do. So we receive a referral. We receive about 1,000 referrals a year. We contact the family, we set up an evaluation, and if they're eligible, we create an IFSP, which is an individualized family service plan. And all of that needs to be done within 45 days, and that includes weekends, holidays, ice storms. So this kind of tells you where we are as far as our referrals, the number of evaluations we do. So not all of our referrals make it to evaluation 7. And then our enrollment. So really, most of the kids we evaluate are eligible for services. And eligibility is not that they have a delay. It is in the state of Alaska, sadly, it is that they have a 50% delay. So not all kids are eligible for our services. They also certain diagnosed conditions that are known to result in a developmental delay, like Down syndrome, autism, those are automatic diagnoses. And then we get to also use what we call informed clinical opinion, which means if there just isn't a test to measure how a kid's doing, sometimes these are kids that have like significant sensory dysfunction. So we clinical opinion those kids in, and then as you can see, our referrals and our enrollment have stayed pretty steady, and it's because of this eligibility criteria, which is the most stringent in the United States. And we're trying to change that. So we have legislation that has been introduced to drop the eligibility from a 50% delay to a 25% delay. Because 50% delay is not really early intervention, is it? So we're trying to do that and get some money so that, because it will increase our roles by 77%, which is awesome. We love that, but we need a little bit of cash to do that, right? So just to let you know, Senate Bill 178 was introduced last year by the Health and Social Services Committee on the Senate side by Senator Dunbar. Hopefully it will go through this year, we're hoping, and to add $5.7 million to the infant learning program, which has not had a raise in 13 years. So I think that's it. We have some activities. So Meg, it's nice to meet you. And nice to meet you. We provide Swaddle Me bags. So they are gifts to all newborns born in Anchorage. So we distribute those through Providence, ANMC, Alaska Regional, and JBEAR. So it has little gifts in there, developmental milestones information, and board books from Help and Grow. We also have a diaper pantry that is open twice a month for families in need. And we give out diapers and wipes to those kids. And then we are also going to utilize that to do developmental screenings with those kids and vision and screenings as well. So and I put these down, it's that upside down, not like that. So on Sunday afternoon, we have pick a truck, which is we bring in all these fire trucks and dump trucks and garbage trucks, and kids get to climb in them and take pictures of them. And then there are indoor activities. It's all outside. So it's really fun and it's free. And we just ask that if people can bring a pack of diapers to add to the diaper pantry, that would be awesome. And that's it.
I got a question.
Oh, sorry.
Go ahead.
Oh, I was just gonna say, my husband texted me about the truck events.
It is so funny, because it's in October, lots of little kids come in their Halloween costumes, because I think they just got them and they just wanna wear them every day. And so the little ones that come dressed like firemen, and then they go to the fire truck, and these firemen are like, oh.
Great recruitment tool.
Yeah.
So the state just asked for regulatory input on infant learning program for the state. It just came out this morning, and so would you be willing to put together, take a look at the state request and then put together like what you would recommend that we change or keep or whatever?
So if somebody wants my opinion on what
I would like that. I've been asked to look at the regulations and put it as submission for South Central Foundation. So it'd be
Awesome.
very helpful to have your input.
I will look that up and I will send that. I also have a request. From him.
Did you get our money?
I don't know.
Find out, let me know.
Another function of our partnership.
I
don't get to see Andy very much. I gotta.
I know, like twice a year at these things. No, so part of that is, part of the eligibility expansion is that we want to include, diagnoses to make kids automatically Part C eligible. And we want to expand it by a couple of things. So right now, prematurity is not an automatic diagnosis. We think it should be. Especially extreme in prematurity. Also, if they fail a autism screening because of the fact that, I don't know what they meant, but that we have this backlog of kids that aren't getting diagnosed with autism. And then unilateral hearing loss. There's a couple others, but I need help from a physician to kind of go through that list to see what you think of our ideas. Okay, so I'll email. Okay, thank you all for letting me do it.
I went to the pick a truck event last year and, there was just as many adults in those people as there were kids. And guaranteed the best day of all those drivers' life. Like, this is their favorite work day. So absolutely come, even if you got kids in the neighborhood who you want to bring to the event, it's really amazing. And also just want to give huge just encouragement and just like a sense of pride for Amy and her team and all the other ILP workers across the state. They had to be so loud last year and work and advocate and get people to understand a lot about early intervention. And we are all now more educated because of your care and compassion and ability to teach us what you all know. And so I'm just so proud and grateful for you all. And we have another year of it, and great partnerships like this are important for that. So thank you for all you do and for your presentation. Dr. Dugan, great, thank you.
Hey everyone, Don Dugan, I'm the medical director of Alaska Cares. So that's Alaska's Child Advocacy Center, tucked under Providence. Nothing traumatizing here, all friendly images, just wanted to give kind of an update about Cares and just to educate everybody who we are and what we do. So Cares, the child is a child advocacy center, and the model of a child advocacy center is that a child can come in and tell their story once, have it recorded and not have to repeat it. Having come previously from an area that didn't have a CAC initially, children would literally cart it around and have to tell their story over and over again. So, you know, literally imagine a 5 or 6 year old who bad stuff's happening to them at home and they have to repeat that story over and over. So first to somebody in OCS who's responding, OCS person, right? And then they have to talk again to the investigating component of OCS. And then they have to talk to a patrol officer who then is followed up by a detective and then a medical provider and then a psychologist or a therapist. And then the DA, and then have to go on the stand. And so, you know, up to 9 to 10 times these kids were telling their stories. And so we started this, I didn't start it, this concept was started to minimize that trauma, that process on our patients. And so Alaska Cares was the largest CAC in the state. Again, we're hospital based. And so kids will come in and they'll meet with the staff. It's a very friendly environment. And all of you are welcome to a tour. So if you're ever in the area, please feel free to come by, take a tour. I just gave a tour to a pediatrician who came from Nome. Who wanted to see it. So yeah, you guys can, everybody's welcome. It's beautiful, there's so much artwork and it's so kid friendly. But the child will present there, we're gonna go ahead and see the child. Child get a forensic interview done, which is a type of interview technique done by a forensic interviewer, so it's not a big scary policeman. It's actually somebody who's very friendly and it's in a warm environment. The interview is recorded and then we do our medical exam. And our medical exam is similar to the way you guys do medical exams, except we're taught to collect evidence. So we'll take photographs, we'll go ahead and collect swabs if it's indicated on the patient. We render treatment, including antibiotics in the office if we need to, or do testing, and then the child goes home. So that's pretty much the process, how it works. In cares, we're unique in that we have a mental health component. There's a lot of CACs out there that don't, so we have in-house staff that are therapists, and we can call them if we need be. We also have law enforcement that's in-house, they're in a separate wing, but they're inside the same building, and then we have OCS as well inside the building. So we have all these partner agencies that are co-located, so we can, so the team can work more efficiently on behalf of the child. We also have advocates for both Providence and SCF. So there's a unique set of advocates for each. So if it's a patient that's impaneled, the SCF advocates will see them. And if it's a non-impaneled patient, then Providence advocates. This is actually our exam room right here. And we have this little polar bear. There's actually a funny story. There was a child once that came from a remote village. And the only child I heard of that was scared because, this child encounters polar bears and, polar bears are actually really scary. They're hunted, right? So, other than that though, polar bear bet usually goes off pretty well. You can see, yeah, they're all painted. We had an artist came in and she did just the most amazing job. And we had her paint the waiting rooms as well too. So there's kind of different rooms to each room, all very Alaska friendly, and just beautifully well done. But yeah, this is basically our exam, and we have a piece of equipment called the Cortex Flow, which is right here. It's a camera. It's a very advanced piece of technology. If any of you photographed in the room, like with a Nokia or with a Rebel, Canon Rebel, picture the Canon Rebel mounted on a stand with basically a computer attached to it. And so normally with like a Canon, when you do exams or when we bring it to the hospital here, you can take pictures of a single target, it'll be in focus, but everything around it will be a little bit blurry. This thing allows us to take a picture and everything's in focus. So it's really valuable from a forensic standpoint, especially when we're taking high definition genital photos, that we get a really crisp, clean shot so we can identify the injuries. But that's otherwise it, guys. It's all the other basic medical stuff that you guys do. This is the team, myself, I'm the medical director. I have 5 nurse practitioners that I supervise and then 3 CMAs. Any positive exam or kit, meaning a sexual assault kit, I review all those cases. So if we're concluding it's gonna be physical abuse or neglect, I review all those cases. If it's a sexual assault kit, regardless of what the results are, I review all those cases too. And the goal for this is that there's consistency. So as I'm in my 2nd year here, as time has gone by, if you read our notes, they start to sound the same, right? And that's intentional. We're using the same language, we're discussing the same findings. And we're making sure that there's consistency. So if you're asking Mary Kay or Tara questions, like you're asking me, that makes sense. And this is our provider line. So this is a number that's out there for you guys. I have a policy at our clinic, and there's no such thing as a stupid question. And I mean that. Like I tell people that. If you're calling me as a provider, ask me a question, or one of my nurse practitioners, you're calling me for a reason. So please don't hesitate to call. This is 24/7. Don't give this out to patients. This is just for providers. Medical provider line. And this number goes to an empty on call. You can go ahead and ask them any question you want, anytime in the day. If they can't answer your question, they'll call me. That's pretty rare. But yeah, so anyway, this is out there for you guys to have. You can put it in nursing stations, put it in your offices, but please don't hesitate to call with any type of question you have. And just because you call us doesn't mean you're triggering an OCS response, right? We have been many calls we filled where we're like, nope, that doesn't mean pressure, or no, I'm not concerned, it's probably a medical reason. So just kind of keep that in mind. And just in general, I think, I'm not sure what everybody's perception is, but in my experience, my career, about half the cases I'm consulted on, I say are non-abuse. About half are abuse. So we get a lot of non-abuse cases. That's my job, is to call something, right? Is it a sister or is it an 8% of abuse? And so a lot of the calls we get, we end up concluding non-abuse. Sometimes the medical team's worried about abuse, and we're the only ones saying, no, it's not abuse, guys, right? So just keep that in mind. This is a number you can call. I want you to feel, welcome, and I want you to feel like you can answer it. You can ask any question. That is pretty much it. If you get any questions, does anybody have any questions for me? No traumatizing pictures. Yeah,
I know you said you worked with OCS, but if we're like calling about a patient, do we call you and OCS?
yes, so in the scan policy for Providence, you call OCS law enforcement and you call us as well.
Okay.
And that gets the process going, and then we can talk to you guys. Now, but let's say you have a medical question, let's say you're like, I'm not sure if this is abuse or not, if I need to report this, you can call us for that too.
Okay.
Yeah, we can answer that question. Yeah, we have questions. Any others? Awesome, and yeah, like I said, guys, there's a number, oh, yeah, I'm sorry, oh, yeah, in the back.
I was slow to raise my hand. I'm just curious about what kind of volume you see on an annual basis, like.
Oh, it's a great question. These are yours, I mean, several hundred cases, so 600, 700, I think when you're 800, like it can be really busy volume. And it's feast or famine, like we might have a day, no cases, we might have a day like Friday, where we had 4 interviews going at once, like we had to run 4 teams, I jumped in and did one because we're so busy, so. It just depends, yeah. We see a lot of strangulation, we're seeing more of that, and then I don't know if you guys are aware of our trauma numbers, but for children who are between the ages of 0 and 14, when they're diagnosed with a TBI, the rate that it's child abuse, determined to be child abuse, at least in our hospital here, is 63%. The national average is 19%. So we have a much higher rate of abusive head trauma up here. I had just last week, I was consulted and I went and sat and testified on a case of just found head trauma of a patient seen here died. So we do see a lot of that here, unfortunately. So just bearing in mind that even though we're a small state population wise, we have a high rate. Yeah, but that's a really good question. Yeah, and unfortunately, hopefully it gets so slow one day, I run out of a job, but that's not realistic. Yeah.
Can you say about how many are repeat? That?
That's a good question. We do get some repeaters. Yeah, we'll get some that are, for one thing, completely unrelated, present for another by a different person. That's not uncommon, unfortunately. Sometimes we'll see teenagers that are multiple different sexual assaults. So it's sad. Most of our patients aren't repeats, if that makes sense. The majority are like first time, but we do end up having some that we see back for other reasons. Yeah, which is unfortunate. Yeah.
We put polar bears on our PG uniforms that scare the hell out of half of it. So.
Yeah. Yeah. We think there's any possibility of that, we just use one of the other rooms. Yeah, we have 3 examiners luckily. I thank you guys, appreciate it, thank you.
Hi. It says Virginia up there, which is good to know because that's how you'll find my email, but I go by Ginny. So, same person. Sometimes people are like, I can't find you. I guess before I get started, since this is an opportunity to collaborate, I'll talk to Dr. Hirschfeld and Amy because we talked to Susan Kessler, who was the state head of IOP last year about our early detection program and how helpful it would be for providers through early intervention to be able to do periodic developmental testing and not have to screen them out, like determine they are in or out the first time they see them, because we know that these issues with motor development and things can become more apparent over time, and we want to establish a trajectory. So as we talk about regulatory and what we would like to see, that was one of our asks. Away from the screen in and out, but being able to screen that. I know. So hopefully all of us collaborating will result in that for our children in Alaska. So when we're talking about early detection for cerebral palsy, we want to recognize that while 40% of new diagnoses come from preterm infants, which are infants who probably spent time in our NICU, 60% are term infants that may not have an apparent history when they're first born. And that if we employ this early detection pathway, we can decrease the age of diagnosis for cerebral palsy by 9 to 16 months. And so that is very important because we know that earlier intervention is more effective because we can take advantage of interventions that are specific to that infant's brain injury. So if we compare that to an adult who's had a stroke or other brain injury, our therapies are tailored to their injury. When we look at infants, sometimes they just get once weekly therapy, which is a lot less frequency and intensity than an adult with an injury. And it's really important that we're getting in there with more
specific, intense, and frequent intervention. Because the difference for an infant from an adult is that they're laying down these pathways for the first time. So rather than rehabilitating an existing pathway, we're creating their repertoire of the pathways that they will have for the rest of their life. So this one brain that they live with forever. We also want to meet families where they are and, meet them with their expectations. A lot of people are really hesitant to have these conversations with families, but what we learned from the literature is that families already suspect something is not right with their infant. And they're actually experiencing a lot of anxiety and more depression when they don't feel met by their medical team with the same observations and a plan for what to do for their baby. So when we are providing early detection, we are also providing families with a validation of what they're seeing and a plan for how to help their child. So we also know that a lot of resources take a long time to establish. So being able to diagnose earlier gives you the diagnosis that gives you access to early intervention, gives you supports in place like TEPRA. And so we want to be able to provide these diagnoses in a timely manner so these families get support. So this is the international guideline for early detection for cerebral palsy. It talks through what are the newborn detectable risks and what are infant detectable risks and what are the steps that we should take. So what we want to do for babies that are identified in prematurity and from our NICU is to provide a Hammersmith infant neurological exam at 3 months. We have defined criteria for who gets a term equivalent MRI, and we are going to provide a general movement assessment, hopefully in the NICU or around term age, as well as at 3 months of age. And the tempo, I feel like now has been replaced by the AIMS. That'll be correct, Jim. So the Alberta and the motor scales. So we are using this triangulation of neurological findings, motor findings, and brain imaging findings to decrease this age to diagnosis. So this was published in 2017. So this is well established in the literature, and articles have come out since about how to implement this in your setting. Now my slide doesn't want to. Oh, sorry, it's highlighting more things that I just talked through. So if you're curious about how what work we have done here in Alaska to establish our early detection program, we've been building the local capacity to provide general movement assessments for the last couple of years. We've certified 30 therapists throughout the state in the basic general movement assessment. And I think it was like around 16 to 20 that returned earlier this year to participate in the advanced training. Jim has provided us with HIME tutoring, and we have reviewed the evidence to make sure that we are doing what is most up to date here at Providence. So we have looked at all of the criteria and tried to kind of hone them down so that we don't overwhelm our capacity to see families. So there's definitely room to expand our criteria, but we're starting with where we can provide the best care in the most timely manner. Through Tim and Jim and I, we have connections with all of these experts, Dr. Matry, Dr. Paige Church, Dr. Dusing, and multiple other people around in the national and international community that have taken a look at our criteria and validated that we are doing the right thing here. And we're starting with referrals from the NICU population, but we are presenting to all of you and looking forward to the symposium in November, so that we are also calling in infants from the community that might have the infant detectable risks. So this is kind of what the pathway looks like. If they're coming out of the NICU and we have concerns right away, we might see them at 1 month to a month and a half. For me as a physical therapist, knowing how much mother-infant attunement can inform later development, I like to use that visit to help kind of heal and repair the trauma of the NICU and help them recognize their infant's cues and provide a positive interaction between the two of them as a foundation for further therapies. And then at the 3 month visit, that's that really important window for the general movement assessment and starting to establish the trajectory on the HIME. So then we want to see them again at 6 to 9 months, and then when we see them around a year, we're gonna complete a full Bailey to look at all domains. And if we feel like we're not sure which direction they're headed, we can add in another visit around between 9 to 12 months. So what we would like to see every child with risk factors receive in Alaska is the 3-month, the 6 to 9 month, and the 12 to 18-month visit. And so we want to communicate this, and we are communicating it out of the NICU. There's a paragraph in all of our discharge summaries now that's written by the therapist and included by the provider in the discharge that says this is what their scores are as they leave the NICU, and this is their recommended interventions, or that they receive this periodic developmental test. And that can be in their local community if you have someone identified that does GMA there. Doesn't have to come back to us. We just want the pediatrician to be aware to look for these testing scores in those timeframes. So they can help us detect and diagnose cerebral palsy earlier, which has been done as young as 3 to 5 months when you have all of those pieces of information. So for us coming out of the NICU, these are our referral criteria. If you are a pediatrician and you're looking at your infants that are visiting you in the clinic, it's looking more at inability to sit by 9 months, any hand function asymmetry, or inability to take weight through the bottoms of their feet when placed. And there are more. There is also this risk calculator that has been established in the literature that looks at term-born risk factors that has a really nice population, and we'll share that more in the future. So we are hopeful that we can all get on the same page in Alaska to speak the same language about development and have all of our infants be provided the same standard of care. So this kind of shows how the direction that an infant might take from the NICU into the early detection pathway. And then the arrows back and forth to community provider, as if the therapists are seeing the child in the early detection pathway here in our pediatric therapies clinic, then we would be communicating with their pediatrician the results of those tests if they were referred right out of the NICU, or that pediatrician might refer into us at the time that they're noticing those moments of concern. So when we have scores and we're having a concern, we're also developing a network of providers that we can refer to follow up and help us confirm diagnosis. So we are speaking with our neurologist here, Dr. Wilson, and as well as neurologists at Seattle Children's and the physiatrist at Seattle Children's to help be a part of this network that will provide care to our infants, and Dr. Lopper here in our PMG pediatric group as well. So we are looking forward to discussing this more in November, and feel free to reach out with us with any feedback or questions that we might be able to clarify in November, so we can have time to adjust our presentation. Are there any questions right now?
Do you have a big wait list for Molly Fuentes at our rehab clinic?
Yes.
Go ahead.
Yeah.
Platform.
I would just like to add that at PIC, we have found a way around the state system of screen and release, catch and release, that we actually don't release them until they are more than 6 months corrected. We keep screening them.
Great.
And those screenings are generally done with our physical therapists.
Right, so,
Yes.
yeah, and I know
Even though
some of
they
that.
said that, we don't do that. But don't tell them that.
We did have a comment from Katie Milliken from South Central Foundation's Child and Family Developmental Clinic, saying that their clinic has they have a birth to 3 clinic, 1 OT and 1 PT, now trained in the GMA for early screening and testing for CP diagnosis as well. And they're working on creating a similar flow like you guys, and thank you for your work.
Yeah, thank you. Yeah, Juanita Luna Green, your nurse practitioner, also came to the advanced training. So yeah, it's great to be able to collaborate and be doing all the same things for our babies. Any other questions?
Oh, I think Dr. Cantor just had to step out, so we're gonna go. To the next presentation and bring them back. Dr. Zoe? Yes. And, or Nicole and.
Dr. Galloway, not you, but I did, I don't know kind of where we're at, so she might pop in and she said if people have questions specific for her contact info is in here, so feel free to reach out. So I'm Nikki, and I'm just gonna talk a little bit about our outpatient pediatric sedation program here at Providence. Our location and hours, so we're a small team, but a robust team. We have 3 primary nurses, Amy Robertson, Holly Himmler, and Mallory Vigil. And they are specifically trained to ped sedation. And we are in Tower D on the 3rd floor of pediatrics. The phone number for the ped sedation nurses is listed there, as well as their fax number. And if you're internal or have access to Epic, then they're also available via Epic Chat or Teams. And we also have a website here at Children's Hospital of Providence. I'm the nurse manager of the program, and my number and email is listed there. And Dr. Galloway is the medical director of our program. So who we are, we have highly skilled PICU nurses and our intensivists and hospitalists who expertly evaluate each patient and deliver the sedation. So we'll walk through the pathway of how it works, but basically a referral goes to the nursing team. And then based on that, they can delineate what the child needs to be able to appropriately do procedures for little kiddos that maybe have a hard time otherwise getting the procedures done. We also work closely with our child life team, and Dr. Galloway wanted to highlight this point that sometimes a referral comes to us and we may think they need sedation, and it's really great because the trained sedation nurses with our child life team end up being able to actually provide the appropriate developmental care to the patients, but maybe they don't even need sedation, but we think they do, but we have skills and techniques we can try first. And then if they need sedation, we advance that pathway as well. This program also enables patients to receive necessary procedures, tests, or lab work locally in Alaska. Without a ped sedation program, these patients would have to either get scheduled in surgery and need a breathing tube and a lot more to get these tests done, or go out of state to do so. And our nurses serve at the bedside, so if somebody calls that number and you don't get an answer, please know they will listen to the voicemail and call you back. They just do care coordination as well as the bedside sedation. So our referral and care process, the provider from wherever within the state of Alaska sends a fax referral to our ped sedation nurses. Those nurses will call the family and do an initial screening and determine the referral needs, the appropriate level of sedation, and get a general understanding of how urgent this might be as well. If there is a prior authorization that's needed, then the clinic or the radiology team here will submit necessary documents to the insurance. And then when we get the PA back, we schedule the patient, give the family a call, and get them on our next, usually it's our next week that we can get them in for that MRI, CT, whatever the need may be. The day before the procedure, our nurse calls the family, confirms the appointment, and then on procedure day, that same nurse who they've been getting coordination with all along is who they meet up on our peds floor. They do pre-procedure sedation and the post-procedure until they go home that exact same day. So what is sedation? Just on a really high level, and you probably mostly know this, but basically when people come to us, it helps the patient become calm, less anxious, but not need to be under sedation and anesthesia to the point of needing a breathing tube, being unconscious, and needing assistance with a ventilator. So it's pretty great, but there's a pretty big scale from minimal sedation to moderate to deep. And we can do all of those. It could be that we give the meds by mouth, through the nose, IV, and basically the child is still somewhat awake to some level so that we can safely do the procedure and get them home. So these are some frequently referred procedures. So VCUG, so the kiddo might need a Foley, and you can imagine as an adult, I don't want to have a catheter. As a kid, you really don't know what that tube is there for. MRI, CT, we've been getting a lot of the neurodivergent autistic lab draws sent to us because a kiddo otherwise maybe can't get their blood work back to know where they need to go to next. So those kiddos have been coming to us just to do more basic sedation to be able to give them the needs they need. Renal biopsy, bears, TEEs are higher risk cardiac and airway patients. LPs, bone marrow biopsies, which kind of loops in with Dr. Cantor's presentation, burn dressings, wound vac changes, Botox injection, or basically anything that requires interventional radiology or something that a kid otherwise won't sit still long enough for the procedure to get done and do it in a way that they're not traumatized for healthcare issues later in life. These are some frequently used medications we use. We use nitrous oxide, ketamine, propofol, Versed, Precedex, or any combination. And like I said, sometimes they come to us and we really think we're gonna need all these things, and we can strategize and work with the family to have them not even have, to have them have a positive experience, and they can go home without even needing some of these meds. If people have more questions, as this is just the basic introduction, feel free to call me or email, or Dr. Galloway's information is there as well. Or if you have any questions right now. Yeah,
First of all, good to see you again.
yeah, you too.
Do you, what do you guys use most often for kids with autism who need sedation for lab draws? Is that nitrous or?
They have been using a lot of the ketamine, actually.
Ketamine, okay.
Mhm,
Like a
yeah.
single shot?
Mhm,
Okay.
yeah.
Yep.
Yeah, the ketamine has been working the most, and then they've been talking about, there's some studies out there, and Dr. Galloway would be the person to ask this to, but there's some studies out there and some combined intranasal with ketamine, and it's been a really positive experience. So she'd be, again, the best resource for that. It's worked really well.
Thanks, man.
Yes. All right, well, thank you so much.
Sorry, no, I saw you got a phone call and any help. It was like perfect timing, yeah. Hi, I'm Emma Cantor. I'm one of the pediatric hematology oncology doctors at Alaska Pediatric Specialties. Oh, hold on, wait. So our group is, we have a group of 3 physicians and 1 nurse practitioner. And we work we do inpatient service at Providence, we do inpatient consults at AMC. And then we have a clinic, that's currently on Lake Otis, but we'll be moving to Providence, to the T Tower at the start of next year. And then we do clinic at AMC outpatient a couple times a month as well. In terms of the kinds of things we treat and we see, we do hematology and oncology, so we do blood and cancer stuff. And we do a pretty wide scope of things up here. In terms of blood disorders that we treat kids with any sort of abnormal blood count. So that can be red blood cells, anemia, it can be thrombocytopenia, which is platelets, or neutropenia, which is white blood cells. And within those can be things that kids are born with. So we get consults sometimes from the NICU. Due to like either an inherited condition or something that happened acutely in the newborn period. For anemia specifically, we get a lot of consults for iron deficiency at any age. The iron deficiency in the state of Alaska is much more severe than any of the other places I've worked at. So we get a lot of consults for that, and sometimes kids can take like an iron pill and get better. Sometimes kids need something like IV iron. Thrombocytopenia are kids who they normally present with extra bleeding. And then neutropenia, when kids have that, they can lead to more infections. We also treat kids with bone marrow failure, which means that all 3 of those cell lines, the red blood cells, the platelets, and the white blood cells, all are not being made by your bone marrow. And bone marrow failure can be from a number of things. Sometimes it can happen after like an illness or something like that. Sometimes it can be something that kids are born with. And we can do some of the treatment here. If kids need to get something like a bone marrow transplant for bone marrow failure, we can't do that in Alaska, and we send those kids mostly to Seattle. We treat kids with inherited red blood cell disorders, which include things like G6PD or hereditary spherocytosis or pyruvate kinase deficiency. And those are all things that just make kids' red blood cells not normal, and they're not as stable, and that can lead to things like anemia. So their body's making red blood cells, they're not good red blood cells. They break open often, and the kids can have issues from that. We also treat kids with thalassemia and sickle cell. And the sickle cell kit, the thalassemia and sickle cell kids, we have kind of scattered throughout the state. And those are kids that we generally follow throughout their whole life. Sickle cell disease is also becoming a disease that has a lot of options for, gene therapy and bone marrow transplants. And so we work with the Seattle team as well for those things. And the Seattle team, actually, their bone marrow transplant team comes up 3 times a year, does a combined clinic with us in our clinic. So patients are able to do at least the initial consult and learn, like, what is the bone marrow transplant? Is that something I'm interested in? Like, is that a good next step for my treatment? They're able to do that all in Alaska at our clinic. So they don't have to go down to Seattle for that step. If they decide to like proceed with the bone marrow transplant, they do have to go to Seattle. But otherwise, we manage all the complications of sickle cell, which are like cardiac complications, breathing complications, and pain complications. We manage all of those at either here or like the call I just got was that there's a sickle cell kit at the hospital in Fairbanks that they need recommendations on what to do. We also manage thrombosis, so blood clots and anticoagulation medicines. The one thing that we do not do at our clinic is bleeding disorders. So we don't treat kids with hemophilia or von Willebrand's disease. There's a separate clinic in town that's run by Dr. Shannon Norman that specializes in that. And that's like a multidisciplinary hemophilia clinic that has like physical therapists and all the services that hemophilia kids need throughout their lifetime. So we just try to kind of, just due to patient numbers, we just condense that all in one clinic. In terms of oncology, so cancer stuff, we are a children's oncology group site, and children's oncology group is the nationwide oncology group that makes all of our protocols for treatments. And they also run the vast majority of the research studies for children with cancer. As a member of COG, that basically means that if a kid comes to get treated at Providence, they're gonna get the same chemotherapy regimen that they would if they presented to a hospital in like Florida or California or anywhere else, because we all use the same protocols, and then we can offer them most of the same studies that they can offer at those sites. Sometimes there are specific studies that we just due to our lower patient numbers than somewhere like Seattle, we can't open all of the studies. So sometimes we'll have to send kids down for a specific study, but the vast majority of the time we can offer kids the same treatment that they can get anywhere else in the country. In terms of the cancer diagnoses we treat, there's a lot of different types of cancer. The biggest thing we see is ALL, which is acute lymphoblastic leukemia. And the treatment for that is about like 2 to 3 years. So the first 6 months to a year is a lot more intense treatment. And it requires a lot more inpatient hospitalization. And then as kids go on over the course of the 3 years, it becomes more of an outpatient treatment. So the first like week to a month, patients are often admitted for that whole time. And that we cannot do those admissions at ANMC because we don't have the nurses there are not trained to administer pediatric chemo. So anytime a patient needs pediatric chemotherapy, either in the hospital or an infusion center, it has to be done at Providence. But those kids get admitted here, and I think Nikki's gonna go over some of the different services that our nursing staff provides those families with during those admissions and throughout kind of the course of their therapy. AML is a different form of leukemia that is a little bit more aggressive and different to treat. It's a shorter course of therapy, but it's a much more intense form of therapy. And so we generally send those kids to Seattle also, just because the level of immunosuppression that those kids get is pretty similar to a bone marrow transplant. And we just don't have the resources to have patients that are that immunocompromised on our units. We can treat kids with Down syndrome AML, which is it's just a different protocol, and kids don't get as immunocompromised. For lymphoma, we treat all sorts of different lymphomas. And then for solid tumors, we treat things like Wilms tumor, which is a kidney tumor. We treat neuroblastoma, and then we do like ovarian and testicular tumors and different sorts of sarcomas, including like bone and soft tissue things. And then brain tumors, we treat mostly in conjunction with Seattle. So we do not always have, depending on what the tumor looks like, The surgeons in Alaska are often not comfortable managing that, or like doing the initial tumor resection, and most brain tumor therapy starts with a surgery and then moves to chemo later. So most of the time, we send those kids to Seattle from the get-go. They have their surgery. Often they'll have their radiation there too, because while our sedation team does a great job with all the procedures, unfortunately, our radiation group up here can't do as much sedation. So kids that need, especially brain tumor kids that have to like lay in a specific position and get radiation for a prolonged period of time, we can't do sedation for that. And so they often go to Seattle for the radiation. So they'll stay there for surgery and radiation. But again, because a lot of cancer therapy is on the spectrum of like years, we can't send kids to like live in Seattle forever. So they generally come back to us and will continue their chemotherapy after they've gone through the initial stages. And then with the help of the sedation team up here, we're able to do all their follow-up imaging and stuff like that. And then we'll present the patients at the Seattle Neurotumor Board conferences. So the people who are specifically trained in neuro-oncology and neuroradiology and stuff like that are still reviewing the kids' scans. So they're able to get like just as high level of care as they would anywhere else, kind of utilizing a combination of resources between us and Seattle. Sarcomas are a little bit similar to the brain tumors in that way too. Not all of our surgeons, not all of our orthopedic surgeons are comfortable doing big tumor resections on kids. So if the kid needs a surgery that we can't provide in Alaska, we'll send them down. They'll generally stay for surgery and radiation and then come back for chemotherapy. Neuroblastoma is an abdominal tumor in kids, and that requires 2 like mini bone marrow transplants. And we can't do that phase of their therapy in Seattle, so we'll do their initial chemotherapy, their surgery. We send them down to Seattle after the surgery to get these 2 bone marrow transplants, and then they come back here. So we try to do as much as we can here. That we have certain limitations just based on the specialists that we have in the state and people's different comfort levels with different kinds of things in kids specifically. A lot of times our surgeons are adult surgeons that don't feel comfortable doing everything. The other thing we do is post bone marrow transplant care. So like I said, the Seattle bone marrow transplant team comes up 3 times a year. And we do a combined clinic with them when they're up. But in between, a lot of the bone marrow transplant kids need to be seen every couple of like weeks to months. And so we do all of their care in between that time and manage all their immunosuppression and other agents that need to be managed. We also see kids with a lot of different genetic conditions that are like what we call cancer predisposition syndromes. So that includes things like neurofibromatosis, which can lead to tumors in the brain or the abdomen or other places. It includes Fanconi syndrome, which is just a general cancer syndrome that can lead to bad cancer anywhere. And then a number of other syndromes like Dicer-1, dyskeratosis congenita, Beckwith-Wiedemann, Fanconi anemia, and Cohen syndrome. We recognize that like at bigger centers, there are people who specialize in like each of these diseases. And sometimes like there's a guy in like, there's a lady at CHOP that only sees patients with Beckwith-Wiedemann. That's like her whole job. So we recognize that we're not that subspecialized, but we'll just reach out to those people if we feel like we need help managing a kid. And sometimes a kid will fly out of state to see a subspecialist that only sees their disease once. And then that team is normally pretty happy to provide us with a care plan on how to continue monitoring that kid like for the rest of their life. So I think we try to do the best we can in state, and sometimes we ask for help from people out of state. And I think one of the strengths of our group is recognizing those limitations, and not being afraid to ask people to help us when we need those. This is a map of Alaska, and this is just we went through the computer and pulled kids who have active oncology plans. So this is just the kids who've had like the longer term chemotherapy in the last 5 years throughout the state. The pink dots are basically all the different places when we went through where kids are from. Sorry, it's kind of low text slide, but we had 35 patients from Fairbanks, 24 from Matsu, 9 from Kenai, 9 from Fairbanks, 4 from Juneau, and 6 from Bethel. And then you can kind of see the distribution of all those kids. This is, like I said, this is just oncology patients with like active treatment plans right now. We, in terms of hematology stuff, which is like anemia and things that are a lot more common, we get those calls every day from all over the state. Like now. Yeah, so I think we do a kind of a mix of things out there. I think that's all I have, unless people have questions about what we do or don't do.
We appreciate all you do.
Yeah, thanks. Yeah, feel free. Yeah, I always, if providers have questions, if you're like, you know, we recognize that especially in a lot of the rural places, there's just like a nurse practitioner or a PA or someone seeing adults and kids, and we're happy to provide things that like any sort of help. If people want help with like iron dosing, I'm happy to help with that. We can do it.
I think there's, yeah, I think.
And then, yeah, Nick needs to talk really briefly just about, like the inpatient nursing side.
So Dr. Cantor highlighted all the services that our kiddos have when they come, and then this is just a brief overview of kind of what happens when they come here to us. So our nurses are trained with both an ONC 101 class and APON led by a certified ONC nurse. So that helps us safely provide chemotherapy, recognize those oncological emergencies, escalate them back to the PICU as need be, and have really thorough assessments as well as education to the family and the patients to support advocacy of what is going on, what will you expect. If you go home and this comes up, don't be afraid to say XYZ and kind of help just advocate because it's a long treatment as it happens. We do huddles with APS providers, therapies, the Providence Infusion Center here, and our staff so that we can all be on the same page of where these patients are at in their therapy, what we're doing next. Our nurses partner with Child Life, the parent navigators, all these teams to come together because you just need to do a lot of family support in addition to the important medical support for these patients. And then we do have a CRRT program here with our PICU RNs who can administer CRRT if the patients were to need that treatment while they're here and if they're appropriate and not outside of any other limitations. But that's great to be able to keep patients here and have that continuity of care for those patients here in Alaska. And then we already talked about peds sedations, but those patients requiring LPs, bone marrow biopsies, port needle accesses, all those pieces are able to provide peds sedation on the same unit, kind of the same faces, and it's just kind of great continuity for those families. That's it. Any questions about this piece? And to answer your question, I text Dr. Galloway. So for the peds sedations, she mentioned also she often asks providers to do PO Ativan to come through the door and then do the IM ketamine when they're here, as well as Precedex or Versed. So if you send a referral, don't be shocked if they reach back and say, hey, can you do normal dosing for this to come in? Because it helps get through the door. And then we do that extra later.
Well, thanks.
Yeah. Yeah. We're on to our kids.
Looks like we will finish some time. All right, let's see. So, it was mentioned a few times, we have our pediatric symposium coming up in November 14th, 15th at the Marriott. It is a hybrid conference, so if you can't attend in person, you can attend virtually. If you register, then you have access to the class, to the presentations for, I think, up to 6 months, I think. And we highly encourage you to attend in person because it's a great networking event. And we also have a special 30th anniversary birthday party for A2P2 on Friday night. That will be really fun. So we'll have cake, but yeah, we have a really packed agenda for the symposium. It's online, a lot of different talks, including Ginny's. And yeah, so check that out. And oh, there's our there's our agenda. I don't know if you guys can see that, so it's pretty small. But it is online. We are hiring. Our family support specialist team for Help Me Grow Alaska is constantly growing. We did lose one family support specialist to Hawaii, unfortunately, but we are hiring some more family support specialists, so help us spread the word. You know, someone who's interested. It's a challenging but very satisfying position to be in, and we have Robin and Tracy here. Robin's our Help Me Grow Alaska program lead, and Tracy's a family support specialist too, and can talk about that position if you have any questions. First review of applicants will be October 22nd, so help us spread the word on that. And our materials are available. There's some on the table there that you're welcome to grab, and you can also place an order and we send them to you at no cost through our website. So feel free to check it out. Resources to hand out to families, books, and resources for the providers themselves, the milestone moments. PALPAC, if you are a primary care provider and seeing children with behavioral challenges or needs and could use consultation from my pediatric psychiatrist, PALPAC is available. Whoops, I pressed that. And then we don't have, I'm gonna get to this in a sec. We don't have a partnership meeting in November because of the symposium, but then our next one will be in December in Matsu. And looking like it'll be hosted by Matsu Regional Medical Center. And with that, thank you very much to Providence and to Meg and Dawn for everyone who participated and shared really great information. We will have these presentations available on our website for anyone to check out later. And yeah, if you're interested in presenting at a future partnership meeting, let us know. Thanks, Fran.
Is there any other announcements or updates from anybody in the room or online? We've got some time if anybody has anything else they wanted to share for the good of the group.
We are, I'll just throw in there for PALPAC, as an addition to the PALPAC, that slide. We're excited to be launching a pilot program this fall that is in addition to the PALPAC program called Growing Minds, where we will have a infant early childhood mental health professional providing consultation, infant early childhood mental health, support. Like care coordination, consultation has different meanings for different people, so gotta be careful with the word. Infant early childhood mental health support to providers who are who have young children in their care, and that will be done through Help Me Grow Alaska. And we have contracted with a professional and looking forward to getting started in the next couple of months. We're designing, still in the design phase for that, but very excited to be adding that to our services. And that's in partnership with the Department of Health. That's it from my end.
Well, thank you, everyone. Thank you, Tamar. Thank you, everyone, for coming today and for joining us online. This is just an incredible space to be in and hear all the great presentations. I, not only as a resident here of Anchorage, but also as a parent who has a young child with chronic medical needs. The care here that's offered at Providence and in South Central Alaska in general is just incredible. That you all support one another. There's partnerships. I was just celebrating over here. It's like, look at the connections happening in this room. This is why partnership meetings exist, is to be able to provide that incredible care, all not only here to the families, but to each other. We're only as good as our partners are and who can support us as well. And the care that's provided here at Providence is just incredible. I was just thinking about the different surgeries and things that my son's gone through, and thinking about all the people that I've seen mentioned on the board. I was like, oh, I met with one of them before, and they're so incredible. And so It's just amazing to see all these connections here. So thank you for the incredible work that you all do and the impacts that you make. And I know the days can be long and the situations can be hard, but as a parent, as a family, you know that you're making huge impacts and making positive change for healthy, happy, safe Alaskans. So thank you for everything you all do. And we will see you all in November, right?
Yeah.
For the party at the symposium party. Please have, yeah, grab some food and see you all soon. Thank you all.
Walk.